see if I know how to run the slides. So I'm going to talk about emerging treatment options for the skin tumors, the cutaneous neurofibromas. And I'm happy to say that compared to the last time I talked at this meeting, there are actually some emerging options. As I said, thanks to you. So I have no conflicts of interest. I don't own stock in anything. I'm not trying to pitch anything to you. What's the problem? Well, you know, NF1 is actually the most common human disease where there's a single gene involved. And the reason for that is the gene is the size of a barn, right? So multiple mutations can lead to this disorder. Kids are born, they have some axillary freckles and cafe au lait macules, other little signs, but they're pretty much born looking normal. And then if you have particularly microdeletion or other variants that lead to a lot of skin tumors, there's this progressive disfigurement. And so you can have a normal looking kid that, you know, progressively becomes disfigured, and it's a real challenge. The social challenges, and there's also the skin tumors are itchy and painful sometimes. So it's not just how you look. And the question really is, how can you treat these things in a way that respects the person's individual needs and their life? Is it possible, and this is what I've been working on, is it possible to do local treatments that will inhibit these the growth or presence of the skin tumors early? And I'll show you why that's a problem. So you can have a beautiful little girl who, you know, later on may look like that. The skin tumors begin in ways you cannot see. They're inside the second layer of the skin, the sort of leathery part called the dermis. And one of the things we've learned, they always start at the same depth. I don't understand this. We did an ultrasound study. They're almost always 1 to 1.5 millimeters deep when they first begin. And we can actually see them by ultrasound, even if you can't see them with your eye. Then some of them grow, and we don't understand what makes them grow. They sort of take off frequently at puberty or with pregnancy. And many times the neurofibroma will actually sort of come out of the skin, and then you end up with this kind of grape-like mass that's hanging on the skin. I actually don't believe that all of them grow. We don't know. Some of them may regress spontaneously. So the natural history of the cutaneous neurofibroma is still a mystery. So you see, when you see a patient with multiple skin tumors, some of them are young and early and small. Some of them have been there for a while and have grown to be the size of a grape or bigger. And some of them are inside the skin, which may or may not grow. So what are the treatment options? Well, classically, the answer is there aren't any. And when I first came to this meeting 5 years ago, I was embarrassed to stand up on stage and basically say there aren't any. So the classic approach is to when the neurofibroma becomes large enough that surgery is possible, you can take a patient to the operating room typically, or you can do this under a local anesthesia and remove a few tumors, or you can in fact remove hundreds or thousands of them. And as you can see on the left side of the slide, that gentleman did very well, but that was probably, you know, a 6-hour surgery that cost a lot of money and may or may not have been paid for by insurance. A lot of times the surgical excision leaves some defect, typically a surgical scar. As you can see, that gentleman on the right, he still has obvious skin abnormalities, which are actually due to the loss of pigmentation. So in darker skinned people with neurofibroma, the surgery is a little bit more difficult. So one of the things we learned in the first study that was done here, which was just this detailed ultrasound study, there is a lot of normal skin surrounding these early tumors, and they're very well demarcated. So we just started wondering, is there a way to selectively destroy these tumors without getting out a scalpel and taking people to the operating room, and to do it at a time before this progressive disfigurement occurs. I mean, if you just think about the challenges of being a teenager, whether you have NF or not, I mean, there's a long list of things, right? And you add the burden of disfigurement onto that time of life when we're trying to figure out who we are as adults, and it seems unfair. So the work that we're doing now, and it's my team, which is right across the street, by the way, is where my laboratory is. I'm a pediatric dermatologist, by the way. Most of my patients haven't gone to kindergarten yet, so I'm very motivated to help kids. Here's a list of some of the ideas that we have. What we're seeking is actually a practical, relatively fast, relatively painless way to do this during the lifespan of people with NF who are typically show up every year in somebody's office, typically a neurologist. And can we come up with something where, you know, you just keep this thing under control? That's the question. So what are those options? Well, cryotherapy, that is basically freezing the tumor, and that works. However, it always destroys the cap of normal skin that's on top, and it almost always gives you those white spots. So how about selectively heating that? And we've tried, starting in the lab and now through clinical trials, a number of things. You can stick a little needle into the tumor and pass electricity into it. That's called radiofrequency ablation. That's been done for many years, but it's quite painful and is invasive, leaves a little hole. But it does work well, and we use that as kind of a positive control. Focused ultrasound. I had a role in coming up with the first focused ultrasound machine that's FDA approved in the United States. It's not configured well to go after neurofibroma tumors, but I'm sure it would work. And there's actually a clinical trial undergoing, it's not in our hands, it's over in Europe right now. So I think focused ultrasound is somewhere on the list. And then various lasers I'll talk to you about in a second. Mesotherapy is basically the injection of something right into the tumor locally. And that's actually my favorite right now. A few years ago, I would have not said that, but the work we've done has brought me to believe that that might really be an option for people. There's other things. Photodynamic therapy is where you give people a drug, either locally or systemically, and then shine light that activates the drug. And I'll end this talk by some really exciting new work that is coming from Dr. Plotkin and others with basically a cream or a gel that might inhibit the growth of the tumors. My personal favorites are the ones with the little stars by them on the slide, but that's unproven, so don't take that for much. One simple idea that worked well for us, if you squeeze most of the neurofibromas of the skin, they're squishy. They're like a sponge, very soft, typically. And so we got the idea of putting mild suction on the skin so that the blood would rush into this, and the vessels would dilate in this squishy tumor. And that actually worked very well. You can very simply bring more blood into the neurofibroma than into the normal surrounding skin. And then over the years, we've developed many lasers that target blood vessels. So we built a laser system basically that uses mild suction, plump up the blood in the tumor, and then hit it with a laser pulse that destroys those blood vessels. And what it does to the neurofibroma is it selectively kills the blood vessels that supply it, and then the tumor dies. Okay, so it's a way of denying the tumor a blood supply. And I'll show you how that looks like. Push the button too many times. So here's one of the patients. It's an adult in a clinical study that we're running. And on the abdomen, you can see a whole field of multiple tumors. In these clinical studies we're doing, we're looking only at the small tumors, because in the long run, we want to be able to treat children or adolescents at an early stage. So we're not treating the big tumors here, even though we could. And this is just an example. Right after that laser treatment, you can see that the tumor looks like a bruise. And that's because we've ruptured the blood vessels and cooked them. This turns out to be quite well tolerated and pretty fast. With this technique, I can treat, 10, 15 tumors a minute, right? So much faster than what you would do with a scalpel and suturing and the classic surgery. And also, there's no hole in your skin, so there's no risk of infection. We see that somewhere around 25% or so of the tumors will respond almost completely. And all of the tumors that we've treated this way have some response. So it's quite promising. We're not finished. I mean, we just begun to understand that we can do this. So now we have to optimize the doses and so forth. And we'll be doing that in some subsequent trials. Another idea that worked very well was to take this natural mild detergent. Every time you eat a cheeseburger, your liver puts out deoxycholate as a means of digesting the fats that you just ingested. And in dermatology, there is already an FDA-approved version of that naturally occurring fat digestion molecule, deoxycholate. We inject it into fat as a way of destroying unwanted fat that's under the skin. But it also has this nice ability to dissolve cell membranes. And so we included that in studies where we directly inject into the cutaneous tumors a small amount of deoxycholate, and it actually works pretty well. So we're now running, we're just about to finish the 1-year follow-up on the first clinical trial in 40 adults with these small tumors. We're comparing the deoxycholate, 2 different lasers, and as a positive control, the radiofrequency needle that I mentioned. All 4 modalities are given to all the subjects. So in each person, we can compare how did they do with this one or the other one. And it's quite interesting to me. Not everybody is the same, and no surprise there, right? So some people do better with one or the other. And I think in the long run, we're going to come up with more than one option. I don't look at this as a single winner. I think for different types of people and different colors of skin and so forth, we might need different options. Anyway, we do a single treatment, follow them for a year, and then image the tumors with 3D imaging so we can understand their volume and how that changes over time. And we measure how painful is this, how fast is it, how practical. The goal here is not really basic science. We're just trying to come up with something you could actually use pretty soon to help people. So the result so far is that all 4 of those treatment modalities are significantly effective. And they're safe. We have yet to have any scars, right? So we're not producing surgical scars, not replacing the tumors with a scar. And none of the treatments have stimulated the growth. I was concerned about that. We're messing around with these tumors. Maybe we would do something that would turn them on. And that's fortunately, there's no evidence for that. By the way, I take care of a lot of people with skin cancer. This is a really different story. The cutaneous neurofibromas never metastasize. They never kill you. They're just there making you look different. So in a way, a partial response is really fine here. Like it's unlike cancer where you have to eliminate the whole thing. So this little hard to read scale at the bottom compares our results now. And this is unpublished stuff. I'm showing you this for the first time. You guys deserve that. So if you look at the 4 modalities here, you can see the pluses and minuses of choosing one over the other. And I just sort of make this easy. The ones on the bottom, there's a laser called Alexandrite laser. That's the one we use the suction. And then the deoxycholate, those are my favorites. And we're taking those forward now into the second clinical trial. All of those treatments were able to do about a 25% reduction in the tumor volume. But what's interesting is that some tumors did really well. Some were completely away. And I think as we optimize the dosimetry, we'll get much closer to 100% And of course, I'm an incurable optimist, so don't hold me to that. But all were safe. The pain was quite interesting. We eliminated one of the lasers simply because it was too painful, and I can't imagine doing it easily in children. Deoxycholate injection, it turns out, was the least painful. On a scale of 0 to 10, the average pain scores were 2, and nobody was above 4. So you can actually tolerate that without any anesthesia. The injection was kind of slow, though. So one of our recent developments was we changed the injector to make it very fast, and now the injection we can do, 10 or 20 tumors a minute once you get going. I like the injection because it's low tech. Somebody with a needle and a syringe in Africa where there's no power could do this. I also like it because it's independent of skin color. So the lasers are a little bit intrinsically dependent on how dark the skin is. The darker your skin is, the less likely the laser is going to get to the tumor, and it's going to be absorbed by the pigment in the skin. So however, that laser with suction is the only thing on the list that's actually selective for the tumor. Meaning with the needle, you better hit the tumor. You have to aim. With the laser, you just kind of go over the skin and it works. So those are the two that I think we're going to move forward. Here's our next steps. We're following, I think it's almost 400 tumors in those 40 patients that maybe it's more than that, 600 or so tumors. And we're just about to complete the 1-year follow-up for all of them. We're working to increase the efficacy, the safety and efficacy are there, but the tolerance, we're going to start cooling the skin instead of using drugs for any anesthesia, come up with things where it's done in minutes in an office in the neurology or dermatology office. And we'll start a larger clinical trial in adults, and NTAP, I really should tip my hat to them, has funded us for doing that additional work. And then about probably a year and a half from now, I would like to launch a trial in children and see how they go. But first we'll optimize this in adults. So can local treatments in a medical office setting actually prevent these tumors from enlarging and causing disfigurement? I think so. I think we're going to do this one. And I can't say it'll work for everyone, but I know it'll work for some. And this is really about giving people options. One of the things that I keep meeting are very well-adjusted adults with NF1 who wear their tumors proudly and are ambassadors in a way for this disease. And I think giving options to individuals and families is what this is about. I'm not pushing this off on anybody. I just want to give those of you with this disorder a greater number of options. This is my last slide. I think there's another thing that's happening. This was started by Dr. Plotkin and his colleagues, which is to try to inhibit the growth-dependent pathway of cutaneous neurofibromas. As you know, the MEK inhibitors have shown promise for plexiform neurofibromas, but there's precious little data about how the cutaneous tumors respond. In order to avoid the side effects of giving those drugs throughout your whole body, there's a company that has developed a soft version of it. So you put a gel on the skin, the active medicine goes into the skin, but it doesn't go beyond the skin. It's literally made for your body to destroy the drug before it gets inside of you. So it just works on the skin. There's a phase 1 clinical trial that's underway right now with that drug company. I have nothing to do with the trial, but I was just talking with Dr. Plotkin. It's a blinded controlled study. He has no idea what the results are. But I can tell you that at the molecular level, people have looked to see, is the drug getting into the skin, and is it indeed inhibiting the MEK and its downstream pathway? The answers to that are yes. So I'm excited about this because I think if that trial shows that there's either growth arrest or inhibition of the early tumors, perhaps from forming, or the real home run would be if you can get an existing tumor to regress with a cream on your skin. That would be wonderful, and I'd be happy to put this other work that I've been doing out of business, okay? But I'll bet you that what'll happen is that a topical cream that inhibits tumor growth mixed with practical local treatments are probably going to be synergistic. It's one thing to take away the mass of a tumor. It's another thing to prevent its growth. So I think these things are probably going to be active together. So anyway, that's my talk. And thank you very much for educating me. And I really believe that this NF problem is something that we all work on together. And those are my kids, by the way. I'm a crazy old man, so I'm into kids, and I know you are too. Thank you.